Well, I want to thank everyone who's able to join us today for another in our continuing medical education series hosted by Africa Partners Medical. These virtual training sessions have been a nice addition to our in-person trainings that we've done through the years. I really appreciate the speakers today that have taken some time away from their busy schedules to be with us and present on some important topics. For those that aren't able to join real time, I expect that you're watching this on our recently formed Africa Partners Medical Training YouTube channel. We're trying to archive information so that people can access it whenever it works for their schedules, but we always appreciate individuals that are able to join us real time and are participating with our speakers during the question and answer sessions. Today, Dr. Melinda Harris will be starting us off. She is a longtime participant with Africa Partners Medical. She's participated in virtual trainings and in-person trainings many times through the years, and she's a practicing neonatologist, and she'll be speaking to us starting today about neonatal jaundice.
Great. Thanks for having me. I am a neonatologist at East Tennessee Children's Hospital, and will be starting in January as the NICU medical director there. I trained with Jay and have traveled to Ghana several times over the course of my training, and really enjoyed the time I've gotten to spend there. Hopefully in the future as well. And I'm going to speak about neonatal jaundice today. And I want to start by saying that I geared this talk toward what the AEP guidelines recommend in the United States, and what we typically try to follow within our unit and other NICUs around the United States. Knowing that even within the United States, there's a spectrum of resources that are available. And so some of these are not available at local hospitals and are really only at tertiary centers and in NICUs. And I'm sure that extends as well internationally, especially in countries where the resources may be may have a wider allocation, in that there can be more discrepancy between various hospitals. We see that locally here in the state I live, which is Tennessee, that there's a wide spectrum of availability of resources. And so what you're able to manage within your own local facility versus what you're able to manage at a different facility may differ. And so some of this discussion, some of this information may not all be relevant for what you're doing in your local practice, but gives you a perspective as to what's available in the wider spectrum of pediatrics. And so for this talk, I focused on these objectives, which was describe the role of bilirubin in the neonate, why it's there, why it's increased, what we do with it, or what the body does with it. Describe the different types of neonatal hyperbilirubinemia, know when to initiate treatment for hyperbilirubinemia and what that treatment is. And then also recognize unusual diagnoses that can be associated with hyperbilirubinemia. And so when we see babies present with hyperbilirubinemia, when to know that things seem unusual, when to know that you need to do a little bit more digging, and look for other diagnoses. Okay. So basic bilirubin physiology, as you probably already know, bilirubin is a byproduct of heme metabolism. So as red blood cells break down and heme is metabolized, then bilirubin is a byproduct of that. On its own, in its original formulation, it's poorly water soluble because of some internal hydrogen bonding that prevents it from being fully soluble in water. And that structure is associated with toxicity. So that is the concerning structure of bilirubin. It can then bind with albumin to become water soluble in plasma. And that, because it becomes water soluble, prevents it from depositing in tissues, which is where the toxicity comes into play. Subsequently, it's then modified in the liver and the kidneys and disrupts the hydrogen bonding and allows then for that bilirubin to be eliminated via either bile or urine. Within that, there's uptake by the liver sinusoids, and that bilialbumin complex dissociates. And then the bili has uptake by hepatocytes. There, it's glucuronidated by UGT. And UGT 1A1 is actually what you'll see on some of my subsequent slides to promote excretion in the bile. And that is the conjugated form or the water-soluble form. The unconjugated, there's still some that's released. It's reabsorbed through intrahepatic circulation. In the intestine, that bilirubin that has been excreted is then the conjugated bilirubin that's been excreted is then reduced to uro or stercobilinogens and excreted through the stool. There's also a process that happens within the kidneys as well to allow it to be able to be excreted by the urine. This is just an overall graphic you can come back to that looks at heme catabolism, and you can see that at number 1, you have your red blood cells that are broken down to release heme, which then releases bilirubin in its metabolism. Bilirubin ends up in the liver. It then is excreted through the bile duct to the small intestine, and then is moved through onto the large intestine, where it can become stercobilin or urobilin and be released in the feces. So the urobilin, as the name implies, urobilinogen, goes to the kidneys where it's excreted. There's also a direct route from the liver to the kidneys as well. And so that's how how everybody gets rid of excess bilirubin. Bilirubin can have beneficial effects, actually. It's an antioxidant, and there's been some adult data that shows there's an inverse relationship between bilirubin and coronary artery disease, cancer mortality, and a reduction in obesity or metabolic syndrome. And in fact, anecdotally, when you think about babies that have had a hypoxic ischemic injury, those babies very rarely have significant hyperbilirubinemia, even when we don't do further procedures like therapeutic hypothermia or anything like that that might reduce their metabolism. Even without that, they have a reduced risk of hyperbilirubinemia. And there's some thought that it may be related to the use of bilirubin within the body at those damaged areas as an antioxidant in a time of really high oxidative stress. There are a lot of toxicities, and that's why we talk about hyperbilirubinemia or jaundice. Because elevated levels of unconjugated bilirubin, which is the version of bilirubin that's not water soluble, can deposit in the brain and can result in create a severe encephalopathy. And then something beyond that called bilirubin-induced neurologic damage. A previous term was kernicterus. And so kernicterus is the pathologic diagnosis. Bilirubin-induced neurologic damage more describes the actual clinical scenario that results from these very elevated levels of unconjugated bilirubin. It's normal for all babies to have some degree of hyperbilirubinemia or jaundice, and we call that physiologic jaundice. And there's several reasons why babies have an increased bilirubin after delivery that then trends down over the next several days. It trends up and then trends down, I should say. There's turnover of fetal red blood cells in that period of time. The red blood cells that fetuses have a shorter lifespan, only 85 days, and so they break down more frequently than more mature red blood cells. And so there's an increase in bilirubin as a result of that. The newborn liver is also pretty immature. It has a deficiency of this UGT 1A1. It's actually only 1% of adult activity, and it reaches the adult level of activity at 14 weeks. So there is a significant delay in the availability of that enzyme. And there's also increased intrahepatic circulation. And so what that leads to is there's a limited conversion of the conjugated bilirubin to urobilin, which then allows for it to become deconjugated in the intestine, and that unconjugated bilirubin to then have a reuptake and kind of go through this process again, and allows that unconjugated bilirubin to just hang around a little bit longer. This is a general trend line for what we expect bilirubin to do in babies by age. So along the bottom, you can see that there's the age in hours from 0 to 120. And then up each axis, the y-axis are transcutaneous bilirubin levels on the left in milligrams per deciliter, on the right in micromoles per liter, depending on what units you use in your area. And you can see that there's various percentiles for where the spectrum or range in which we expect babies to be in. But overall, you can see there's a trend up for the first 3 to 4 days, and then a plateau and a trend back down. And so that's what we would expect most babies to do. The concern, of course, is those babies that are up above the 95th percentile or have a more rapid rise than expected. And what that is in relation to their threshold or their ability for their body to tolerate that level of bilirubin. We assess hyperbilirubinemia just through the appearance of jaundice. Jaundice is a yellowing of the skin and mucous membranes. Jaundice can't be detected by eye until it's at least 2 to 3 milligrams per deciliter, or 34 to 51 micromoles per liter. Usually you see it first in the sclera. And so if you look at the eyeballs, you'll see yellow eyeballs, and that's when you know you've got some jaundice. But then it spreads distally. You can also see it in the mucous membrane. So if you look at the palate, that's another good place to see kind of these early signs. But what we're really looking for are jaundice levels that you can see in the skin, chest and below. And so those are the areas that make me worried that the level is higher than I would expect or hope. In most babies, bili peaks at 48 to 96 hours of life. There is some evidence to show that those with East Asian heritage have a little bit later of a peak. And it typically resolves within the first 2 weeks. It can still be present in breastfed infants later on, and we'll talk about that in a little bit. But if there is still a presence, then it's really necessary to continue the evaluation because of the risk of other disorders that are being masked. We diagnose hyperbilirubinemia through the measurement of bilirubin. There's a couple ways to do that. A really common way in the units I work in is transcutaneous measurement, and that's a picture of that on the right. It's a device that measures bilirubin through the skin. It only gives a total number. It doesn't give the fractionated number, meaning it doesn't give the amount of direct bilirubin as well, or conjugated, which is important to evaluate for. So oftentimes we do need to get a serum measurement if the bilirubin is higher than we would expect, and that'll give us the fractionated portion. It's important to take into account the history of the baby. So most importantly, what's the baby's age in hours, because that gives us a lot of information about whether or not that bilirubin level is too high. Whether or not there's a family history of inherited disorders, and we'll go into that a little bit, but there's a group of disorders that result in hyperbilirubinemia, and that can be a good thing, it can be a bad thing, it depends on the disorder. It's also important to look at race and ethnicity in this, and can be especially important when you look at the transcutaneous measurement, because there are certain skin tones that the transcutaneous measurement does not do as well with. In fact, today I just got done with newborn rounds today, saw a baby that is African American, and that baby's bili was reading as high risk, and in fact it was half that when we did a serum. So sometimes this transcutaneous measurement can be a little bit off depending on underlying skin tones. And then also any history of medications that the baby's received. And some, in our newborns, they typically don't get very many meds, but if you have a baby that's a little bit older, they may have had some exposure to some medications. On physical exam, it's really important to note vital signs. Does the baby have vital signs that are within normal limits? Is there any evidence of bradycardia or tachycardia, any respiratory depression? Because that kind of helps us also look at the mental status of the baby. And so what we're looking for here is, do we have an encephalopathic baby, especially if the bilirubin level that you've measured is high. But these are things that might alert you to whether or not you need to look closer at that measurement. If there's any evidence of encephalopathy, the the next steps look significantly different. And then when we look at the skin exam, the extent of the jaundice, how distally does it proceed, if there's any bruising or any area where there's some blood sequestered, so looking for things like cephalehematomas, subgaleal hemorrhages, very large bruising from vacuums, that sort of thing, all can, even if it's not to the extent of a cephalhematoma, still can be impactful in the risk for hyperbilirubinemia. And then evaluating the abdominal exam as well, looking for hepatosplenomegaly, may give you an idea of some underlying disorders that may not be specific to the most common reasons that we see neonatal jaundice. It's important when you get your serum measurement to look and see if this is an unconjugated or a conjugated problem. The serum testing that is done measures the amount of the direct reacting bilirubin and then subtracts that from the total. And there's a lot of information you can look at to just look at this more. I didn't go into the huge amount of the details here in this talk, but just know that the direct bilirubin is slightly overestimated because a small portion of unconjugated bilirubin can also react. And so at times your direct bilirubin may look a little overestimated, but still it's worth a close look if you see something that looks elevated. Some drugs can interfere with the assay. So if you have a baby on propranolol or on lipids, so if you, especially if you had a baby in the NICU that was on intralipid, that could impact that assay as well. But in the end, what you're looking at is, do you have an elevated unconjugated fraction? If so, proceed to the nomogram, which we'll go into. If you have an elevated conjugated fraction, and that seems to be the most impactful part of your bilirubin levels, then this is pathologic, and you have to proceed to a further workup for this. And then I'll talk a little bit about conjugated hyperbilirubinemia or cholestasis, but I geared a lot of this talk towards the evaluation of unconjugated hyperbilirubinemia. When we look at treatment options, we look at treatment options in a baby that has unconjugated hyperbilirubinemia, then the very first thing that should be assessed is optimizing the feeding. So optimally, you would prefer to continue enteral feeds and not interrupt breastfeeding for multiple reasons. One, you want to make sure that mom's milk supply gets established, and the only way for her to have more milk is to continue breastfeeding. Of course, she can pump if that's something that she has available, but it does not supplant the utility of actually breastfeeding a baby. That's going to be what gets her milk supply in the fastest. It's really important to continue to have enteral feedings in these babies because that's going to continue to move food and then subsequently stool through the intestines and hopefully reduce to a degree that intrahepatic circulation that's occurring. Babies should feed every 2 to 3 hours around the clock at baseline, and that's really whether they're bottle or breastfed, but particularly in the case of breastfed babies. Some mothers may need to consider pumping, like I said, if their milk supply really seems delayed in coming in. The next thing I look at is whether or not phototherapy is indicated. And what I really recommend you use is billytool.org, which you may already be familiar with, or pdtools.org, because it's the most up-to-date as to the use of the nomogram and to the AAP guidelines. In fact, it was just recently updated with the advent of the new AAP guidelines that came out this year. And it is very user-friendly. I refer everyone to it. I use it in my practice every single day. You could certainly refer to a printed nomogram, but in order to stay the most up-to-date, I really recommend using one of these sites if you have that available. Phototherapy and the use of it is guided by gestational age, the presence of risk factors, and the age in hours. And so those are all things you're going to need to know when you take a look at these nomograms. The nomograms became significantly more complicated with the new AAP guidelines, and now there is one for every gestational age, essentially a line for every gestational age, as well as one with risk factors versus not. Again, if you use these online tools, it it simplifies that significantly for you. Phototherapy should be guided by serum levels and not by transcutaneous levels if that's available. Transcutaneous in general overestimates what the true serum bilirubin is. Occasionally it can underestimate, but most often overestimates. And so you may have a baby that has a high transcutaneous bili level, but the serum bili is substantially lower, and there's no need for phototherapy at that point. Depending on how the baby's doing otherwise clinically, I may consider supplementing with formula. If the baby's had excessive weight loss, so nearing 10% or exceeding 10% weight loss, depending on the age, and if there's signs of dehydration, so decreased urine output. If you were to do further labs, you may see hypernatremia. Those would be things that would make me consider supplementation with formula. Those would also be things that would make me consider IV fluids. However, I typically don't add IV fluids until if I see a baby that's significantly dehydrated, certainly. But I really start thinking about it when we have babies that are approaching exchange transfusion levels. To obtain the information about those levels as well, I continue to recommend the use of those two websites as being the most up-to-date and being the most informative regarding exchange transfusion levels. You can obtain that information as well through the guidelines, but a simplified version is available on those websites. It's important, if you do start a baby on IV fluids, to continue feeding the baby as well. It's really important to continue to have enteral intake because that, first off, is going to continue to keep that baby actively eating with no slowdown once you start weaning the IV fluids off. But it will also continue, of course, pushing things through that gut, helping to get stool out, and that's how bilirubin frequently is metabolized, as you learned earlier. It also helps just have more volume to have more pee. And in the end, it's really important to have that volume, especially if you're on phototherapy. And if you're on IV fluids, you're typically on phototherapy. The goal total fluid would be 80 to 100 mils per kilo per day. That is typically inclusive of feeds. And so you can titrate your fluids to look at that. In older babies who are a couple of weeks old, that fluid goal may be a little bit higher. And then, unfortunately, sometimes we are not able to manage babies with these initial things alone, and we proceed to exchange transfusion. Nobody wants to do an exchange transfusion. It is not the most fun procedure. And it certainly has a long list of risks to the babies, but at times it is necessary, and especially with babies that don't have straightforward hyperbilirubinemia. And so again, it's important to follow the evidence and utilize these tools to look at what level that's recommended. If, however, the baby has signs and symptoms consistent with acute bilirubin encephalopathy, then you may need to do an exchange much sooner than those levels that are recommended. Phototherapy is our most commonly used intervention. Like I mentioned before, it works regardless of the etiology as long as it's an unconjugated hyperbilirubinemia. We do not use this in conjugated hyperbilirubinemia. The mechanism is that it converts unconjugated bilirubin into lumirubin, which is water soluble, and as such is not neurotoxic, and it's excreted in urine primarily. And so it's just another way for babies to get rid of bilirubin. In practice, it's important to measure the irradiance that you're giving, and it should be at least 30 microwatts per centimeter square per nanometer, with a wavelength of 460 to 490 nanometers. And most of the blue LED lights that you see are typically that. There are old school lights that we still used up until last year, actually, in our own unit that require a little bit closer evaluation. Because they have a little bit more risk. The LED lights do not emit UV light and have a much lower risk for things like overheating and fluid loss. And so it's important to evaluate the type of light you have and pay close attention to the type of irradiance you're giving. The light should cover as much of the skin as possible. You cover the eyes, of course, and they oftentimes have to wear a diaper, but otherwise everything else should be uncovered and the baby should be as exposed as possible. You should minimize interruptions, especially babies that are nearing exchange transfusion levels. They really shouldn't leave the lights at all. With babies with lower level hyperbilirubinemia, they can come off the lights intermittently to feed, but then should go back onto the lights after no more than about 30 minutes off. There are some great thoughts of ways in which to do phototherapy in resource limited settings that don't have the availability of phototherapy lights. And it was interesting to read about that. There are some films that go on windows that you can use to filter out the UV sunlight that allows you to use sunlight as phototherapy. The risk with using sunlight as phototherapy is the exposure to that UV light that can increase the danger for later skin cancer and that sort of thing, but in the short term can cause sunburns. And certainly in babies, that's concerning. There can also be overheating from that, and there can be an excessive amount of fluid loss from that as well. And with babies with jaundice, oftentimes they're already nearing dehydration anyway, so that can worsen them. Like I said before, the old lights had the side effects of overheating. They had more rashes. You still see some rashes related to phototherapy, but it's significantly less, and some fluid loss. Long-term, there has been some suggestion that babies who require phototherapy have a risk of childhood seizures, childhood cancer, melanocytic nevi, and retinal degeneration, which is why we cover up their eyes. I will say that it's a little hard to tease apart whether that risk is because they had hyperbilirubinemia or because they had phototherapy, and whether or not that risk is still pertinent now with the advent of more modern lights, and whether as we use these modern LED lights, if those risks will go down or not. Sorry, I'm gonna move this box again. Ways to start thinking about when you need to start reducing interventions. So when can you come off of phototherapy? One of the things I think about there is what is the baby's risk for rebound hyperbilirubinemia? And so meaning once you come off the lights at a certain level, what's the chance that that baby's bilirubin is going to jump back up? And there are certain babies that have risk factors for that. So babies who are born less than 38 weeks, so late preterm babies and those that are 37 weeks, early term babies, have a higher risk of rebound hyperbilirubinemia. Babies who have to start phototherapy at less than 48 hours of life have a higher risk. Babies who have hemolytic conditions, which we'll go into detail about, and babies whose bili is close to light level when you're wanting to discontinue it, which there's a lot of questions about where exactly is the right level to discontinue phototherapy. If a baby has no risk factors, my general approach and the general approach of many is to discontinue when the light is greater than or equal to 2 below the light level, or phototherapy. I call it light level. Also, phototherapy threshold would be the other name for it. Getting it at least down to that point, you can typically safely discontinue phototherapy with close follow-up afterwards, of course. If there are risk factors present, there's a couple of ways. There's suggestion in the literature to discontinue when it's less than 12 milligrams per deciliter, or if the light level is below, if the bilirubin level is below light level greater than or equal to 2, you can consider discontinuing, but making sure that you're rechecking a level within 6 to 12 hours of discontinuation, with a low threshold to restart if the baby's on the trend back up, if the trajectory of the bilirubin increase looks like it's going to exceed light level soon. It is important to remember that follow-up bilirubin, if it's done within 24 hours, should be a serum and not a transcutaneous. You can start using transcutaneous after 24 hours off of phototherapy, but before that, it really needs to be a serum to best evaluate what the bilirubin level is in that baby. Um, this is a picture of the exchange transfusion levels, and this is in the older literature, just as an example of what this looks like. But again, I would not use this slide to determine your exchange transfusion level. If you were to do one, I would again look at the AP guidelines. You can use the goal of an exchange transfusion is just what it sounds like, which is to take blood from the baby and then put donor blood into the baby. And the goal of that is to remove as much bilirubin as you can. Most often we're doing exchange transfusions in babies that have an underlying hemolytic condition. And so with that, you're also removing some of the reason for their hemolysis frequently, which we'll talk about. But the ultimate goal whenever we're doing this is to try to reduce the amount of bilirubin in the blood. And so because phototherapy is so effective, the number of exchange transfusions we do now is significantly less than it has been in the past. And so we do not do them very frequently, which is great because it's a somewhat risky procedure, and it certainly is time consuming. So you're going to, for that, most often the general approach is using washed typo red blood cells suspended in compatible fresh frozen plasma. And so that compatible word is really important because if you have a hemolytic condition that's related to blood incompatibility between mother and baby, then it is really important to make sure that that FFP also is compatible. It does require central access. Optimally, you would put in a UAC and a UVC, larger size catheters, because that makes it way easier to be able to do and a lot faster. If you're only putting in a UVC with 2 lumens, then it just is, it's a little bit slower of a procedure. And then you're wanting, this requires continuous monitoring. So these babies need to be on cardiac monitors continuously to monitor for any concerning trends. And we also regularly check labs, especially potassium and calcium, but also platelets during this procedure to monitor for where we're at as we go through the procedure. And there's some great guidelines out there that you can look at. In fact, every time I do this, I go back and review the guidelines so that I can make sure I remember, because I just don't do it as often as I know other neonatologists have in the past. We're going to talk about a little bit about the disorders that you may run into that can cause unconjugated hyperbilirubinemia, and they are divided into 3 areas: overproduction, reduced uptake or decreased clearance. In overproduction, the underlying problem is hemolysis, either extravascular or intravascular. In reduced uptake, which we're not going to talk about any more than this slide because it's very uncommon, there's reduced hepatic blood flow for some reason. So heart failure, portosystemic shunt, or some drugs can cause this. But in these circumstances, this is a very uncommon reason for neonatal jaundice. So I just mentioned that to be thorough. And then the last area is decreased clearance. And so that can be either inherited or acquired. In inherited conditions like Crigler-Najjar and Gilbert syndrome, then those things can happen. And I'll talk about that in more detail in a moment. There are some acquired reasons. In neonates, this is where we find our physiologic jaundice. This is where we find breast milk jaundice and breastfeeding jaundice. But hypothyroidism and liver disease can also result in decreased clearance of unconjugated bilirubin. And there are some drugs that can as well. These are uncommon drugs for us to use in neonates, but possible. Protease inhibitors are used for treatment of HIV and certainly potentially could be used in these babies. Ketoconazole and amitriptyline, much less likely to be used in neonates, but just to have that awareness, especially in slightly older children, if you were to need especially ketoconazole. So hemolysis, divided into extravascular and intravascular. When I think about extravascular hemolysis, I think about when blood extravasates into tissues. And so that's where cephalhematomas, subgaleals, extensive bruising all come in. And so that's where that blood has extravasated and is now breaking down, and all of that heme and subsequently bilirubin is being released. You can also see that with hypersplenism, which is less common in neonates, but possible. Intravascular hemolysis, and this is things like red blood cell disorders. So G6PD would fall into this, sickle cell, thalassemia, hereditary spherocytosis, hereditary erythrocytosis, alloimmune hemolytic disease of the newborn. This is where you think about ABO incompatibility, minor blood group incompatibility, RH incompatibility. Infections can cause intravascular hemolysis. There can be autoimmune hemolytic anemias, microangiopathic hemolytic anemias like HUS, TTP, and DIC. So very, very sick babies, especially in the DIC. And there can be drug-induced hemolytic anemias when you think about use of cephalosporins, penicillins, and Bactrim. It's uncommon, but it's possible. I'm going to focus on alloimmune hemolytic disease for a moment because that's a common reason for babies to have significant hyperbilirubinemia. And what happens here is that there's destruction of the fetal or neonatal red blood cells by maternal IgG, which can cross the placenta. And that can occur when that fetal or neonatal red blood cell expresses an antigen not expressed by mother. And so there can be major incompatibilities with RH and ABO, and there could be minor, the most significant being things like Kell and Duffy, and there with those incompatibilities. It can range from asymptomatic all the way to hydrops fetalis. And so babies can be very sick when they're born due to underlying alloimmune hemolytic disease. These babies are typically DAT or Coombs positive, and that's one way you can help identify it early on, even if they're asymptomatic at birth. When we think about RHD, it's the presence of the D antigen on the red blood cell of a fetus in an Rh negative mom. This is most important in subsequent pregnancies. In a first-time pregnancy, it's unlikely to cause any significant effect because there's very little mixing at that point. However, in subsequent pregnancies, it's important to recognize that that mother needs RhoGAM to reduce the risk of developing a subsequent hemolysis in that next baby, especially because it can occur in utero and frequently does occur in utero in that situation. It can result in very severe disease. They're at high risk for hydrops. And so with the advent of RhoGAM, we see very little of this anymore. It's very uncommon, but still something to remember, especially if you were to get a mom that didn't have any prenatal care. ABO incompatibility primarily occurs in moms that have O blood type. There is a paucity of A and B antigenic sites on neonatal red blood cells, which makes it less likely in moms of other blood types. This is an area where we really don't see hydrops. We do see babies that have APO incompatibility that have severe hyperbilirubinemia as neonates, but we really don't see a lot of fetal effects in this scenario. In minor group incompatibility, there is, again, that can be more severe on fetuses. There is a risk for hydrops there, especially with some of the, with certain antigens. Moms get antibody screens, of course, during pregnancy, most often, hopefully, that will pick up on some of this. But we do watch for that in babies that have excessive hyperbilirubinemia that we would not have anticipated, or if we have a baby that's born with hydrops with no clear reason why. And again, Kell and Duffy are the most common antigens to cause problems in this way. Typically, babies that have alloimmune hemolytic disease have unconjugated hyperbilirubinemia within the first 24 hours. They can have symptomatic anemia that also comes with that. And so it's important to evaluate their baseline hematocrit. Occasionally, you can have a baby that only has the anemia and does not have the hyperbilirubinemia because they're in some way able to metabolize it and excrete it. If it's significant enough, again, they can have features of hydrops. The way we approach this is that all babies of O positive, O negative mothers or mothers with a positive antibody screen have a blood type in Coombs or DAT following admission. It's possible that even in the circumstance in which there's an abnormality, the DAT can be negative just because of the way in which that test is run. But it's uncommon. Most often that test is a helpful addition. We follow babies who are Coombs positive or DAT positive with more frequent bilirubin screening. So every 6 hours is what we do. The recommendation is at least every 12 hours. We do transcutaneous bilirubin, so it makes it real easy. The AAP suggests in their newest guidelines that there should be 2 checks, Q4 following delivery and then Q12 thereafter. And so we are altering our guidelines in response to that, but actually it's suggesting we do it less frequently than what we were doing before. If the bilirubin trends up quickly, nearing our phototherapy threshold or light level, then at that point we obtain a CBC and a reticulocyte count to start trending where those are falling. We follow the guidelines for the initiation of phototherapy and then follow bilirubin closely after the initiation. It's really important to get a repeat bilirubin within 4 to 6 hours following initiation of phototherapy in this particular circumstance, because these babies can have a very quick trend up in their bilirubin and require much more extensive management. There is no contraindication of breastfeeding, but the biggest thing is to avoid dehydration in these babies. So in first-time breastfeeding moms or babies that are not breastfeeding well, you may need to supplement with formula to try to avoid having dehydration exacerbate these already high bilirubin levels. We monitor for symptomatic anemia, so looking for typically a crit less than 25 is really when we're concerned, and transfuse if it's necessary. If these babies are continuing to trend up despite intensive phototherapy and nearing exchange level, then we consider giving IVIG if it's available, primarily to try to avoid doing an exchange transfusion. The goal, and there's some really good evidence to suggest that it prevents exchange transfusions. The evidence is less clear about the other outcomes related to this, but for that, there is evidence to suggest that it does reduce the need for an exchange transfusion. But if it continues to escalate really rapidly, that baby does need to be assessed about the need for an exchange transfusion. Other sources of hemolysis are hereditary spherocytosis, hereditary elliptocytosis, enzymatic defects within the erythrocyte like G6PD, pyruvate kinase deficiency, infections. The theory behind that is that there's increased oxidative stress due to sepsis, sequestration, like we talked about, and then infants of diabetic mothers have a higher risk for hemolysis, partly because they do have a higher risk for polycythemia, but there is also suggestion that they may have ineffective erythropoiesis. Jay, I'm running over. Do you want me to stop or do you want me to keep going?
I guess it depends on how much you think you have left.
Probably about 5 or 6 minutes.
Well, let's have you finish up in 5 minutes, but we'll skip the Q&A so you can just put that in the chat.
Okay, great. Okay, so the next topic is decreased clearance. And that's when some of these inherited disorders come in. So things like Gilbert syndrome, which is a defect associated with glucuronidation. It's most commonly actually not diagnosed until you're a teenager and adult, but can present in neonates. And that's primarily just due to the reduction in this UGT1A1 activity. And these are kids who have jaundice that's triggered by viral illnesses, fasting, physical stress, things like that will trigger them to have some jaundice that then is picked up on lab exam. It's benign, it requires no treatment. It's really a diagnosis of exclusion to some degree. And the biggest reason to diagnose it is just so that these kids aren't repeatedly worked up for this jaundice. Crigler-Najjar syndrome is an autosomal recessive syndrome that's also related to a deficiency or absence of this UGT1A1. Type 1 presents right after birth and can proceed very quickly to bilirubin-induced neurologic damage. And these kids often require chronic daily phototherapy. There are some meds that are suggested for use, but really the baseline treatment for that is chronic daily phototherapy. Type 2 presents in infancy, and there's a wide spectrum of severity just based on the amount of enzyme present. And these kids are often managed with chronic phenobarbital and then phototherapy when they have an exacerbation. In babies that have increased intrahepatic circulation, there's a risk for hyperbilirubinemia. And so babies that have a functional or anatomic obstruction to their GI tract have a risk for having this increased intrahepatic circulation. And so these kids are at risk for hyperbilirubinemia. And when you think about some of the GI defects that we see, gastroschisis, omphalocele, duodenal atresia, all those sorts of things, there can be a risk. Breastfeeding jaundice or inadequate intake, specifically in late preterm babies, that's a real high risk, but it's at a risk for any baby, first-time breastfeeding moms. And then also breast milk jaundice. And I think, yeah, I go into further detail. So breastfeeding jaundice, again, is really related to inadequate intake. It's really more of a dehydration jaundice. And so these babies have slower bilirubin elimination. And so because of that, because things aren't moving through their GI tract as quickly, they have increased enterohepatic uptake of unconjugated bilirubin. Late preterm babies are at the highest risk. Primarily because when they're breastfeeding, they're probably just not doing a great job of it. They're probably not transferring milk as well. Their moms may have a slower time getting their milk to come in. It's very highly influenced by complications with maternal breastfeeding. And here we tend to exacerbate that by having such short lengths of stay in the hospital or inadequate postpartum support. And it's a really common reason for hyperbilirubinemia in the first week of life. Breast milk jaundice is different. Breast milk jaundice, really what that looks like is persistence of a benign hyperbilirubinemia beyond the first 2 weeks. It can persist for weeks, but it's typically resolved by 12 weeks. So it's the babies that you see that are a month old that still have some jaundice. That's all unconjugated. It's an unclear cause, but it may be related to high levels of beta-glucuronidase in breast milk, which increases that reuptake of unconjugated bilirubin. And the biggest thing here is just to make sure that it remains unconjugated. It doesn't require phototherapy because it typically doesn't exceed the recommended thresholds. And then just to share about conjugated hyperbilirubinemia for a second, or cholestasis, when you look at your fractionated bilirubin and you see that your direct bilirubin is high, that's when you should really be concerned about something pathologic. And I've listed here some of the things that we worry about when we see that. Most often it's due to an impairment in the excretion of bile, and that can be through obstruction, through infection. There's a very lengthy list of genetic or metabolic disorders, alloimmune underlying causes. It's very uncommon, but possible. There are toxins that can be involved. And then what I see most often in my job are the miscellaneous ones. So the babies who have had shock or hypoperfusion, the babies that have an intestinal obstruction, those are common reasons that I see for cholestasis. The other one being TPN. That's a really common thing that I see in my practice, but probably is less common out in the general pediatric world. The biggest thing to think about is that if you have a D-bili greater than 1, you really have to go down this whole path of ruling this out. It's very important to rule out biliary atresia early because biliary atresia can have an intervention for it depending on the availability of that surgical intervention. And then beyond that, it's important to test to identify the cause. So ultrasounds, liver biopsies, blood work. You don't treat conjugated hyperbilirubinemia with phototherapy. It causes something called bronze baby syndrome. And as long as your unconjugated portion is not excessive, then there's no reason to treat direct hyperbilirubinemia. It is important to add water-soluble vitamins to the baby's regimen if your D-bili remains elevated, because there's some concern about the ability for the liver to process that. And there is a role for the use of phenobarbital and ursodiol to treat this, but it depends very much on what the underlying cause is. So in our approach, as I said before, we obtain a cord blood type and DAT on moms who are O negative or those that have a positive antibody screen. If they have a positive Coombs, we check a transcutaneous bili every 6 hours during hospitalization. If that bili is nearing threshold, then we obtain a serum bilirubin to verify. And then we begin lights when the baby's within 1 to 2 of a phototherapy threshold. In babies, all other babies who are not Coombs positive, we check a transcutaneous every 12 hours. And again, if it's nearing phototherapy threshold, get a serum bili and then begin lights within 1 to 2 of light level. At times, we wait until after. If the baby's going to be maintained within the hospital and under observation, we may wait until they exceed light level. But again, it's very dependent on that history and the scenario that we're in. And then we want to make sure that there's no other factors that we can optimize in babies that are nearing that threshold. So in summary, unconjugated hyperbilirubinemia is one of the most common diagnoses in neonates. It's important to have a systematic approach to evaluate for all of these different types of causes and look at your history and look at your physical exams so that you don't miss any key findings. And again, phototherapy is a very safe and well-tested therapy, and we're fortunate to have it. And that's all I have. I apologize for going over, Jay.
Well, thank you so much, Dr. Harris, for a very clear and comprehensive review of a very important topic. And this will be nice for archival purposes. If there are questions for Dr. Harris, please feel free to put them in the chat, or if there's time at the end, we can address them as well. But we're going to move on to our second speaker for today's session, Dr. Peace. And Dr. Enna is trained in anesthesiology and is currently a Mayo Clinic scholar receiving special training in pediatric anesthesiology. And she's going to speak to us today about something that's, I'd say, near and dear to my heart, is how to decrease some of the challenges and discomfort related to doing necessary procedures with pediatric patients. So thank you, Dr. Enna, for participating today.
Thank you. We'll go ahead and get started here. All right, so I'll just go ahead and get started. Give me a second to, does that look okay?
Yeah, it looks good, thanks.
All right, so so I'll go ahead and talk about procedural comfort measures for pediatric patients, and already did the introduction. I'm happy to be here. I've been to Ghana once to visit a friend, and I hope to visit again as part of this group. All right, so the things that I wanted to cover with this talk, again, what is really our goal when we talk about pediatric procedural sedation, or, providing comfort for our pediatric patients that are going through procedures. And then first, again, the whole idea is to be safe while we do this. So we'll talk about how we can assess a patient if they're suitable for procedural sedation. And then understand, what the procedure actually needs and how we can do that, and what type of monitors we need to provide safe sedation. And then understanding the depth of sedation also, I'll talk more about this as there's a continuum. And then also what medications we can use to achieve the depth of anesthesia sedation that we need. And then also we'll very briefly talk about how we can create a safe sedation plan. All right, so what is procedural comfort measures? When we talk about it, again, it's a group of techniques or medications that we can use to minimize anxiety, pain, or movement during unpleasant and unavoidable procedures. Again, you'll hear me talk a lot about this, about the, priority really being safety. And if a procedure is not necessary, then, it's best to avoid doing it. But again, if we need to go ahead and do the procedure, then what techniques can we use to provide, help our patients be more comfortable during those? And then again, a lot of times, we think about pharmacological interventions, but there can be some physical or psychological tools that we can use to help our patients go get the procedures that they need. And then, like I mentioned, this is a continuum. So that means that, there are different levels to it. And, we have to really think about the procedure and the patient, and then choose wisely what depth of sedation that we need to provide for the patient. All right, like I mentioned, again, when we talk about pediatric procedural sedation, the question I'm asking myself, how can I safely and successfully complete a necessary procedure in the least distressing way to the child, okay? And so this will really guide the way that we come up with our plan and go forward to make sure that our patients are comfortable when they're going through procedures. So this is a schema, just a diagram that kind of helps break down the necessary steps that we need to take. And I like that it starts with assessing the child again. So this is important. We're not just creating a plan in vacuum. We really need to assess the child and see what they need. And then we now talk about the environment and the personnel that's needed. And then, thinking about who is available, what kind of monitoring equipment do we have? And then we need to prepare the child and the parent about the procedure that is going to happen then, before going ahead to choose the best technique to provide sedation for the child. And then again, in assessing the child and assessing what we have available, we need to also be thinking, about other personnel or other skilled providers that we need to get involved if we think that the patient is not suitable for a regular procedural sedation. All right, so talking about the patient, it's important really to know what the age of the patient is and where they are in their developmental and behavioral status. Again, you know, taking care of a patient like a infant baby is very different from a teenager in terms of like their development and like their ability to communicate with you and what they will need. So it's important to understand where the child is in terms of as they're coming in. And then obviously, as you know, as important with any pediatric case, weight is very, very important for the patient because that's how we dose our medication. So those two things are, you know, key things to know off the bat. And here I have a table showing, you know, kind of breaking down those age groups and what, you know, what we understanding them a little better about what they need. So again, you know, if the kiddo is less than 6 months old, at this age, they don't really need much. More of the stress is on the parents because, you know, you're taking their little baby for a procedure, but a lot of times the kids don't need much in terms of sedation. If you can, you know, swaddle them and keep them comfortable, that might be all you need for depending on the procedure. But then as they progress to, you know, over 6 months old, you know, up to that 4 years old where they're, you know, the terrible twos, then, you know, at this stage, they're not really understanding of what needs to happen and they can get easily scared. And so the, you know, the tools that we need for this age group will be different. You know, they tend to do like magical thinking, and they can, you know, throw temper tantrums. So again, a lot of distraction and doing baby talk might be necessary to help them get through the procedure. When they get to 4 to 8 years of age, they can begin to understand, you know, if we explain in simple terms what is needed. But then again, they still have that fear of separation. And so again, a lot of plays, magical thinking, explanation will be necessary in this age. And then again, as they get into school age and become adolescents, then this is where, you know, you can really, you know, explain to them what to expect, and that can help sometimes alleviate the anxiety that comes with these procedures. And then more on the patient. So we talk about comorbidities for the patient again. Before we go ahead and provide sedation for any patient, we need to know, you know, what they're coming in with. So if they have any history of any chronic diseases or any genetic abnormalities, especially if it has to do with the cardiac or respiratory system, this is really important for us to know. We also are interested in finding out about their airway history, if they had any prior procedures and how they did with those. What medications they're taking or what allergies they have is also important. And then we also care a lot about if they've had any complication with any sedation or anesthesia, because again, our goal is to do this safely. And so if they've had any allergies or if they've had any complications, it's important to know those so that we can avoid those medications or have a better plan for managing those. And then this, I don't really want to delve too much into this ASA classification status, but this is what we as anesthesiologists use to classify our patients, you know, help us to triage or determine their risk for going under sedation or anesthesia. So just really wanted to highlight ASA 1 and ASA 2 groups. Again, these are normal, healthy patients or patients that have very mild systemic diseases. These are patients that are, you know, typically they're okay to go ahead with a procedural sedation. Once they start getting to ASA 3 and ASA 4 and 5, these are kids that have, you know, some congenital cardiac anomaly that's now fixed, or they're really young, you know, less than 6 weeks of age, or they have some airway challenges, you know. So these are the ones that should probably not be done as a procedural sedation. It should probably involve someone more, you know, someone that has more experience with taking care of pediatric patients, like a pediatric anesthesiologist. And then finally, on a note on the patients, again, we want to do an exam to, again, assess their risk. So if during doing the airway exam, if they have any craniofacial syndrome, you know, any genetic abnormalities or any tumors, burns, scars, or radiation in their face, Or if they have, you can ask them to open their mouth, and if there's like any lingual mandibular abnormalities, or if they're missing a teeth, or they have a, very large tonsils that we call kissing tonsils, or if they, when you ask them to, move their neck, or they, try to move their neck, if they're not able to do that safely, those are patients that we should probably be more cautious of and probably involve, other healthcare team members, just to make sure that they're safe, because they have higher risk for, if we give them sedating medication and they get too sleepy or too sedated, then we need to rescue their airway, and it might get more complicated than that. So those are things to be on the lookout for. And then fasting status. So this is the general guidelines for fasting before general anesthesia and sedation. So clear liquids, 2 hours is usually the recommended time. They should, the last fluids they have should be 2 hours before the procedure. If it's breast milk, it's 4 hours. For formula and other non-human milk, it's 6 hours. If it's like light meals, like, tea and toast, it's like 6 hours. But if it's any fatty meal, then 8 hours. But again, these are general recommendations. And if it's an emergency case, then obviously we have to weigh the risk and benefits of waiting for the appropriate amount of hours versus going ahead. The reason that we care about their fasting status is, again, sedation is on a continuum, and sometimes you might be, wanting to do very light sedation, but then the child might get too sedated and might need their airway rescued or do a procedural mask them. And if they have food in their stomach at the time, there's a risk that it might come up and go into their lungs and cause some chemical injury to the lungs. And so that's why we care about the fasting status. So it's something to keep in mind and think about. Again, like I said, if it's an emergency situation, sometimes you have to accept the risk of this aspiration happening. But then if we can wait, it's usually advisable to wait for these time periods. And then, moving over to the procedure that we're, doing. So it's really important to understand what the procedural need is, so does the procedure need just, a quiet baby, someone that's not anxious, or do you need some pain control, so they need to get some analgesia? Do they need to be sleeping and sedated for the procedure, or do they need to just not move? And again, these are trying to understand what the procedure is and what they actually need for us will help us plan better. So these are some examples of procedures and the goals that they need. So again, for some diagnostic imaging, so say like a CT or an ultrasound, sometimes all that they need is medication for anxiety, or, if there's other ways that, like I'll talk about non-pharmacological ways that we can get them to relax and cooperate, that might be what is needed. But even in that diagnostic imaging, like an MRI, you might actually need them not to move so that you can get good imaging. So that will all factor into what comfort measures or sedation that you provide the patient. And then for the diagnostic, these are, sometimes painful procedures. And so at this stage, you have to think, is this like a very short, like, if you're putting in an IV, it's going to be a very short, painful procedure. But then after the procedure is done, then it's no longer painful. So that will help you plan for something that's short acting, that can wear out easily. But then, for an LP, a lumbar puncture, right? It's not as short of a procedure, so they might need more to be able to cooperate. And then for therapeutic, again, if you're fixing a fracture, dislocation, changing the dressing, you might need longer term, you might need pain control at that moment, but then subsequently the patients might need something on board for pain. So all of that really helps us in planning what our sedation or what we're can provide the patient. And then it's also important to think about where the procedure is happening. A lot of the time, these are happening in the emergency department or in the radiology suite or in the dentistry office. But sometimes they can be happening in the intensive care unit, or, blood draws in the laboratory, or even in the office. Or the office. And I'm curious to hear other places that, sedation can, happen on your end. And so again, the reason that it's important to know about the location is that different tools might be available to you based on the location, right? So if you're on the emergency department, there's likely to be more, nurses or other providers that are available to assist if anything happens. And the amount of resources or monitoring that's available is also different compared to, happening in the primary care office where you might not have everything readily available to you. So it's really important to know where the procedure is happening so that you can plan better. And then in terms of the plan, again, we'll talk a little bit more about the depth of sedation that we're trying to achieve and how we can achieve that. So this is important for the plan. And then I'll talk about equipment and monitoring. And really the goal is to choose the technique or the agent that's able to achieve the anxiolysis or analgesia, sedation, immobility with a quick onset and a short duration so that it will allow successful performance of the procedure with a quick recovery and discharge. So this is what we're trying to do. That's our goal. And so in terms of the depth of sedation, so this is how we generally talk about the depth of sedation. And, we talk about it in terms of the responsiveness, what's happening to the patient's airway, if they're able to do spontaneous ventilation and what their cardiovascular function is. And so for minimal sedation, a lot of times we refer to this as anxiolysis. This is where a patient is awake and they're relaxed, they're able to move and they're able to respond to normal verbal stimulation. So they might be uncoordinated, but they're still able to respond to you. Their airway is usually unaffected in this scenario, and they have spontaneous ventilation. Their cardiovascular is also unaffected. When we talk about moderate sedation, sometimes we refer to this as conscious sedation. This is where the patient is now in a depressed level of consciousness, but they're still able to have purposeful response to verbal or tactile stimulation. So, if you talk to them or you just touch them lightly, they will be able to respond to you. Again, their airway, we usually don't need any intervention. They're able to spontaneously breathe on their own and their cardiovascular function is maintained. When we talk about deep sedation, this is where they're still able to have purposeful movement, but in terms of the stimulation that will get them to move, this will be repeated stimulation or painful stimulation. So again, they're in a deeper level of sedation here. And in this case, since you have to really stimulate them to get them to respond, a lot of the times their airway, you might need to intervene on their airway in terms of, you might have to put in an oral airway or do like a jaw thrust or something to help support their airway. And then spontaneous ventilation may be inadequate. So they might breathe and then stop breathing. And so you might need to support them. Their cardiovascular function should be maintained, is usually maintained. But again, this is all a continuum. And it's important to note that pediatric patients are at higher risk for unintentionally moving to a deeper state of sedation than desired. So again, there's nowhere where, you say, okay, this is what I'm targeting, and, you give the medication to the patient, and there's no guarantee that they will stay in that level that you're wanting to achieve. So that's why it's really important for us to be very cautious and monitor them. So because there's a chance that they will move from, the intended level to a deeper level, and then we'll have to intervene. And so in talking about the personnel that is necessary or needs to be involved, some of the questions that we can ask ourselves is, who is performing the procedure? Are they available and ready to do the procedure? Because, some of the times if we need to give a medication, you don't want to give a medication and then, be waiting, for an hour for the procedures to show up. You ideally would want to give it in a reasonable time so that the procedure can happen in a timely manner. And then it's always important to be thinking about who needs to be around in the case of an emergency. So again, it's thinking about your location, where you are, and if you can easily get help if needed. And then, thinking about who else should be available. So here, sometimes we need to get help from our child life specialists. These are people that are more experienced with, talking, to the kids, interacting with them. So if that is available to you, should they be available? Or, think about other resources that you have available. Who else needs to be there? Do you need to have the parents available to help, talk to the child? So those are all, or do you need the parent not to be available? Again, those are all the things that you need to be thinking about. And I know we just finished talking about the depth of anesthesia of sedation. So again, it's really important to know that if we're targeting a deep sedation, or if that's what we're going for, we need to have at least 2 people available and 1 person who is performing the procedure. But then the other person needs to just focus on the sedation and monitoring the patient. Again, it's really important because, again, sometimes they might not be breathing as well, or they might, get overly sedated and not be able to maintain oxygenation or ventilation. So we need to monitor them and be able to respond. And then those people performing the 2 people, the clinician and the assistant, again, they need to be trained in how to deliver the sedation, how to monitor the patient, and then dealing with the complications of the sedation. Again, it's really important to highlight here that if the personnel are not trained in those rescue skills, they should not be given sedation. And then just briefly here, these are the minimum amounts of training that those people providing sedation should have. So again, all the personnel that are, trying to do sedation, they should at least have skills for basic life support skills. And then if we're going for a more moderate or deep sedation, then they should have more advanced life support skills. And then talking about the equipment that we need to have available. So again, suctioning, again, we talked about possibility for aspiration. And so it's really important to have suctioning so that we can clear the patient's airway. It's also important to give oxygen because, again, if we're doing moderate or deep sedation, sometimes we might need to supplement their oxygen. And then other airway equipment, you have like the bag mask, the oral nasal airways, and other airway device, even a surgical, something available, not necessarily immediately in the room, but it should be available in a place where we can easily reach them if we so need them. And then we need to have the sedation medications and the reversals, and we need to have our monitors. I'll talk a little bit more about the monitors in a little bit here. And then we need to have IV or fluid catheters depending on the sedation level. And then also, it's important to have tools for cardiac resuscitation, like a defibrillator and things like that, again, available in the vicinity or where we can easily reach them if we're going to be giving some sedation. And here, talking a little bit more about the monitors that we need to have or be thinking about. So again, I kind of break this down into the level of sedation that we need and the monitors that we need to have. So if we're going for minimum sedation and anxiolysis, again, because their hemodynamics are largely unaffected and they're able to respond. So a lot of times, direct observation of the patient is all that we need. However, if we're going for moderate sedation or conscious sedation, we can observe the patients and have a way to monitor their oxygen level and their heart rate. A lot of times we can achieve that with the pulse ox. Some pulse ox have, they can tell you the oxygen level and then it can give you the heart rate as well. But if we don't have that capacity, then we need to have like the ECG to show us the rhythm, the heart rate. And we need to be monitoring and recording these vitals at least every 10 minutes. If the patient is not able, again, for moderate sedation, we should still be able to get verbal or tactile response from our patients. But if there's, for any reason, say, they're too young or they're in a CT scanner and we're not able to reach them in time, or they're developmentally delayed and they're not able to communicate with us, then we need to have a way to measure to check their respiration. So we can do this with a pretracheal stethoscope, listening over the airway to make sure that they're breathing, or we can use like capnography and to check their end-tidal CO2 to make sure that they're breathing. And then if we're going for deep sedation, we need to, again, in addition to observation and the oxygen and the heart rate that we talked about, we also need to measure their blood pressure and also their end-tidal CO2. The end-tidal CO2 is really a great monitor, a great tool that we can use to ensure that the patient is breathing well. It can typically tell us, again, depending on the tracing, if a patient is not breathing as well or if they've stopped breathing. So again, we really rely on the tracing of the end-tidal CO2 or the capnography to really tell us how a patient is doing in terms of their ventilation. And a lot of the time, if a patient stops breathing, you will see it first on the end-tidal CO2 before you even see it on your pulse oximetry. And again, I just really want to emphasize this, that again, even if you have all the monitors in the world and you don't have a personnel that can interpret that data and intervene, then it's really not helpful. So again, the personnel, the person monitoring the patient is really the most important monitor that you can have, because they will be responsible for interpreting the data and also responding in case of an emergency. All right, so I really wanted to do some cases here just to kind of get us to come up with a plan, some reasonable plan for sedation. And so the first case that we have a 4-month-old that's previously healthy. They fell while their sibling is carrying them. And so they need to get a head CT. I don't know if we can do audience participation, if anyone can talk, in terms of thinking about the patient and the procedure, like what depth of sedation do we need for this kind of procedure? All right, so I'll just go ahead and keep going since we're a little short on time. So again, for head CT in a 4-month-old, again, we talked about how when they're this young, they don't really have stranger anxiety or separation anxiety. So sometimes you can just like swaddle or give them like a pacifier that has some sweet, some sugar, and they're able to go through with this head CT without any sedation. Again, in terms of monitoring, just having someone observe them would be adequate, because again, all that we're doing is really minimum sedation in this case. But if say this patient was 8 months old, again, they're that age where they have strange anxiety, and just wrapping them up might not be enough. So in this case, you might need to give them a medication that will help with kind of sedate them or help with anxiety. And then if it was a 4-month-old, again, 4 years old, again, they're at that age where they're very interactive, very aware, but not really understanding what's going on. And so in this case, while this is not a painful procedure, while you need, distracting the kiddo might help, but they will not be able to stay still for the CT scan. So we might have to give them more medication to sedate them and for this procedure. And then, CT scan is a short procedure. And so usually shorter acting, 15 minutes procedure will be enough. But if we're talking about an MRI, which is a longer procedure, this is a case where we might have to do like an infusion of a medication or a medication that lasts a lot longer to make sure that the patients are not only sedated, but that they're very still for the MRI, because we need to get good imaging. So again, this is where it's really important to understand what is needed for the procedure. So again, we talked about agents that we use for non-painful procedures. Again, a lot of distraction, storytelling, and coaching the patients. And these are just some ideas for the things that we can do. Again, when you start getting to the school age and adolescents, you can usually coach them through it. Or, for us here where, the tablet is very rampant, that's kind of a distraction tool that we can use for these non-painful procedures. And then in terms of medication, again, I don't want to dive too deep into this, but I just have a lot of options in terms of medications that we can use. So midazolam, that's now highlighted in red here, is one of our most commonly used medications for anxiolysis and amnesia. And it can be given in a lot of different forms, for PO, rectally, IV, IM, intranasal. And so these are just the dosages, and usually they're able to provide this anxiolysis for half hour to 2 hours. So they're really, very used a lot. And if just used singly, it doesn't cause a lot of respiratory depression. But again, if a patient has pretty severe respiratory disease or have pretty bad sleep apnea, then we have to be very, very conscious about that. And maybe this is not the right medication for them. And then other medications that are sedative, the pentobarbital, that's, not commonly used here anymore, but again, it's available, the thiopental and methotrexate, all of those are barbiturates that are act as sedatives. Again, these don't have any pain analgesics, so this will mostly just be for sedation. And then chlorohydrate, again, not very commonly used anymore. There's actually a moving away from it, but it's something that still can be used, to sedate patients. And you can get it orally or rectally. Nitrous oxide is another adjunct. I'm not gonna talk too much about it here. And then moving on to a second case. So if we have an 8-year-old history of osteosarcoma, just wanting to coming in for an IV placement, they need to get a medication infusion. Again, with the understanding what is needed, IV placement is a very short, painful procedure in the moment. And so some of the things that we can do, is like use a topical agent. We have some local anesthetics that we can spray on the hand and just kind of help numb up that area, but make sure that we put it on maybe 30 minutes to 45 minutes ahead of time so they will have time to work. But sometimes, if the patient is really anxious, even though the hand is really numb, anesthetized, we might still need to give them a little bit of medication for anxiety. Or we need to distract them, say with like a tablet, or have someone, talk to them and coach them through it. And then if another patient, 2 years old, coming in for a dog bite, they need to clean the site. Again, this is a case where it's a minor painful procedure. And so again, distraction might help, but sometimes they might need some moderate analgesia and some anxiolysis. And so these are some medications that we can use for the minor painful procedures. Again, fentanyl is a very commonly used medication here. There's an oral form, but we rarely use the oral form. A lot of times we use the IV form, but this is understanding that patients have to have an IV to start off. So sometimes we can give this fentanyl nasally and it acts well. You have to get the patient to cooperate to put it in their nose, but it's very short-lived and it's quick onset. It has very little adverse effects if used just by itself. And we'll be able to do these short, quick, painful, minorly painful procedures. Morphine and meperidine are also analgesics that we can use, and they have like intramuscular forms. Again, they are more long acting, and so if you want something that will last for hours, this can be used. And then the next ones that we have dexmedetomidine or Precedex. I think clonidine, was around for a long time, but now there's a lot of move to dexmedetomidine. Again, this is a medication that we can give through the nose. Again, has minimal side effects. If you give large doses, it can cause bradycardia and hypotension. But again, this is very rare when given nasally. So again, it has some analgesic properties, but it also can cause sedation. And so it will be really nice for a short, quick, minorly painful procedure. Ketamine is another medication that we can use. Again, it comes in various forms, and we really help because it has analgesic and amnestic properties. The only thing to keep in mind with ketamine, it can cause a lot of secretion. And so just be mindful of that, because there are some procedures that the increased secretion might be problematic. And then the last case that we'll do here, so we have a 3-year-old, playing on a swing, falls and has like an elbow dislocation. And if they're coming for a reduction and casting, again, this is can be a painful procedure. And so the goal here will be to provide dissociative amnesia. and analgesia as well. And so these are the medications that we can use in this case. So again, we talked a little bit about ketamine before, but again, we can give IM ketamine or IV ketamine, and that has dissociative effects. It has analgesia, and we really can get the patient to be motionless to be able to do the procedure, but there's like a dissociative effect to it, so they might see things or just not act right. But again, just being aware that this can happen. And then propofol is a medication that we can use to get deep sedation. And a lot of the times, if we're getting an MRI and we need the patient to be really still there, we can do a propofol infusion. Again, mostly it's IV form, and a lot of these ones for major painful procedures or for IV form. So we have to get the patient to get an IV first before we can use them. But again, since we're targeting a deep sedation level, monitoring is very important, and we need to make sure that they're breathing spontaneously, and that we have a personnel, someone available that can rescue an airway if they get overly sedated. And then again, like we talked about in our toolbox, we need to have the reversal agents for these available. So naloxone is a medication that we can use to reverse the effects of opioids. And this is the dosing, and it's usually shorter acting, so we might need to redose if needed. And then flumazenil is a benzodiazepine reversal, and this is the dose, 10 mics per kilogram per dose. Again, sometimes you might need to start an infusion if the medication that we gave is longer acting than the flumazenil. But again, it's important for us to know the reversals. And then after the procedure is all done successfully, so we need to monitor the patients. Again, depending on the depth of the sedation that they've got. So again, we need to make sure that their vital signs are back to normal and the patient is fully awake and they are not going back into a deeper level of sedation. Make sure that they don't have any nausea or vomit and that they're pain-free. And then, of course, make sure that the procedure is complete. All right, so in summary, again, it's very possible to help our pediatric patients to tolerate brief, stressful, and painful procedures without experiencing significant pain or unpleasant memories of the event, because again, sometimes some of these patients might need to come back repeatedly for different procedures. So it's really nice if we can help them not, have those memories of those events. And then, being able to give this procedure sedation will allow us to do diagnostic and interventions in a timely manner. And, doing them in a daily manner will likely decrease any morbidity from delaying the procedure. And I just really want to highlight, it's really, really important to know the patient and also know the procedure that we're doing, because those two will give us information about what the right combination of sedations that we need and what monitoring we need to have available. Again, teamwork, good communication is very important between the personnel. So again, if say the person monitoring is noticing that the patient is in a deeper level than expected, then they need to be able to communicate that and also call for help. So it's really important just to ensure the safety of our patients that we're able to communicate well. And then, like I said before, again, while we really try to, make the experience as pleasant for our patients as possible, the principle of do no harm still applies. So if we think that we're not able to adequately monitor a patient, that we're putting under any kind of level of sedation, if we're not able to have someone there to monitor the patient, then it really might be best to not provide any sedating medication and just do non-pharmacological coaching of the patient, talking to the patient, talking to the family, and distracting the child to get the procedure done. And if we're not able to do that, then we have to weigh the risk and benefits of delaying the procedure versus proceeding. All right, I know we're kind of short on time, so we'll take any questions in the chat, or we can talk more at the end of the talks. Thank you all.
Thank you so much for a review of another important topic. As a practicing pediatrician, this one's definitely near and dear to my heart. So we'll transition to our third and final speaker of the afternoon, evening. Dr. Emanuela Salia is a physician who's done training in the Johns Hopkins Bloomberg School of Public Health and is currently a postdoctoral research fellow at the University of Tennessee Health Science Center. And Dr. Salia is going to speak with us about the medical ethics of managing friends and family.
Thank you so much for the introduction, and thank you everyone for being here this afternoon and evening, wherever you are in the world. So yeah, my name is Emanuela Lebasana Salia, and I was a participant in the APM conference in 2017, and I'm glad that I was able to join earlier this year as well. And I'm happy to be here to be sharing on the medical ethics of managing ill friends and family. So just to start off, in terms of the different categories of the relationships that we could have between a physician, it can be broadly categorized as physician-family, physician-friend, physician-colleague. And in the colleague section, we have where the colleague could be either a physician or a non-physician staff like a nurse, a social worker, or a pharmacist, etc. And then we can have cases where the physician is providing healthcare for themselves and taking care of themselves as a patient. But for the purposes of this presentation, we'll be looking specifically at the physician-family and physician-friend relationship. So first off, when we talk about a friend or a family, it comes to bear as to what is really the definition of an immediate or a close relative or a friend. And I believe that we would all appreciate that depending on the culture and depending on your setting, a close relative can vary. In terms of immediate, we usually refer to immediate as being a nuclear family member like a parent or a sibling. But what about somebody who is not necessarily your sister or your brother, but a cousin who has lived with you basically all your life and is now married? That person is most likely going to be considered as a close relative. And so terms like this is what brings about the gray areas and then the diversity in terms of what is really right or wrong. And we've all heard the term or the saying that we should treat every patient as you would treat your parent or relative. And so it kind of comes to bear or subtly connotes that the care that is provided to a parent or a relative is likely to be more superior or better quality. But as we'll come to see from the literature, that may not necessarily be so all the time. Okay. So we look at the setting of where this care could occur. And there are two broad settings in terms of either the formal or the informal setting. And the formal setting is more of like a hospital or a medical facility setting where individuals engage with a physician in a consulting room or a more formal, a more structured environment, whereas the informal is basically anywhere outside of that setting, and it can take place from anywhere, as even a church picnic, a wedding, wherever, on a vacation, or even just with normal conversations. In terms of the formal setting, there are some challenges with that, but it is preferable because, as we'll see later on, in those settings, the interaction can be documented and we can have the access to history and other interactions that one may have had. And in the formal setting, in some situations, you actually have no other alternative, given that in some localities, the physician may be the only one available, or that particular specialist may be the only specialist available, and as such, there's no other alternative. However, the informal setting can take place, like I said, anywhere, and medical attention can range from anything from just simply asking medical opinion on a particular case, or asking or requesting for a prescription refill or a new prescription, or even in some cases, tests, the request to order a test. All right. Also, we have to take into account the setting in terms of the practice and the rules that govern the particular organization that one finds themselves in. So in terms of whether you are in a private or a public or governmental institution, there are certain laid down code of conduct and rules and principles that govern the behavior or what is acceptable within that setting. In addition, different jurisdictions have different rules that also govern whether or not the care of the care of family or friends is actually acceptable. And so it's important to know your setting and to be conversant with those rules that govern the particular practice. And so, for example, in Ghana, we have the Medical and Dental Council, Ghana Health Service facilities, and they each have their code of conduct and how it is that physician and even non-physician staff are expected to abide by. And so it's important that in whatever setting you find yourself, you are well acquainted with that information. Okay, but the general consensus is that in emergency situations where life and death is at stake, and one has the tools and the requisite medical knowledge to be able to be of assistance, there is no reason why you should withhold your services from anyone, be it a relative or be it a family member or a friend. And so the general idea is that if it's in an emergency setting, whether it's in the formal setting in the hospital or outside the hospital, it's understandable that
come. My turn. My turn.
I think there's a general consensus that care should be provided irrespective of the relationship that the physician has with the patient. Also, it is generally accepted that in situations where the best interest of the patient at that particular point is to have that care provided, then a physician can go ahead and offer or render the services. But in this case, it's very important to balance convenience with the best interest in terms of whether or not that act or that request or the need for medical attention is more of a matter of convenience than it is a matter of being in the best interest of the patient. And again, we can see that this is a very delicate issue where there will have to be a lot of balancing in judgment. All in all, almost all jurisdictions over the world agree that physicians should avoid caring for people who are close relatives and who are friends. And we'll see why this is so. So as much as possible, you should avoid it. So even in an emergency situation where there are other physicians who are able to take care of that person, it would be better to have them do so. But where there's nobody else and you are the only one, then you should go ahead and offer those life-saving measures to reduce morbidity and mortality. So this is, I really like this cartoon because when we talk about convenience and best interest, this is a situation. So sometimes there's the there's this thought that if people are on a vacation and they've gone to a village for a funeral or and some other family activity, and they are not able to have access to their primary care physician or any other physician who can, say, prescribe a medication for them, then, or render some medical attention to them, then it's like they are stranded. So we always have to weigh this very carefully, because as we can see, somebody on an island is stranded, but he's able to order a pizza. So then that really tells us the importance of being able to judge situations very well and objectively. So why do physicians even sometimes have to face this dilemma of caring for their friends or their families? And I think that some of the reasons, this is definitely not an exhaustive list, but some of the reasons that have been documented is that patients sometimes do not know that there are some cons or disadvantages to having a relative be their primary provider or to provide care for them. So they are looking more at the advantages and the convenience that it puts for them than the disadvantages that could arise from that kind of interaction. Also, genuinely, there are occasionally no other feasible alternatives. And I give you a scenario. So for instance, if you're in a rural setting and you happen to be the only physician there, some of these communities, we become like family, and basically, you know everyone. You have a kind of rapport and professional relation and personal relationship with people. And you may not have the alternative to refer patients to another facility just because of the accessibility that they may have to another facility. And so technically, there are no other alternatives that would work in that setting. In addition, the cost involved. So people believe that once you are having a telephone discussion or in an informal setting, and even in some cases, some of the formal settings, they expect that because of the relationship that they have with you, they are not going to be charged certain things like consultation fees, and for them that is like saving some money. In addition to that, convenience plays a very important factor. And the convenience is not just on the part of the patient, but also can be on the part of the physician. So in terms of the patients, I mean, we know that in certain facilities and in certain settings, the bureaucratic procedures that are involved in being able to get a folder and all of that before you finally see a physician. And even when you are referred, it can take some amount of time before you will be scheduled to see a specialist. And people usually want to cut that time and the inconvenience that it poses to them. And so once they know somebody, they have a relative who can attend to them, irrespective of their expert level or their expertise, they would rather use that avenue. And in terms of the physician being convenient for the physician, if you have a physician who has a child, for instance, and that child falls ill, having to get time off work to take the child to the hospital for care can sometimes be a problem. And so it might just be convenient for them to provide the care that their child or whoever it is needs in order to prevent them from having to take time off work. And that could be some of the reasons why taking care of ill family and friends may be an option. But there's another side of the coin, and that has to be balanced out very delicately in terms of the fact that you have a relative who comes to you and you need to perform a physical examination. And sometimes the nature of the exam can be very sensitive and make both the provider and the patient very uncomfortable. In some cultures, children are not supposed to see the nakedness of their parents. And so that could pose a problem, as we all will understand, in terms of if you even have to do a digital rectal examination or something of the sort. It might be very awkward in those circumstances. And so in that line, you may not have the opportunity to do a thorough physical exam in addition to your history taken, which would help make a diagnosis. In addition to that, even with the history taken, some of the questions that may need to be asked in terms of, most of the time, the sexual history and social history can sometimes be difficult for somebody one is more familiar with, a close relative or friend. And even the answers that you may get may not be the entire truth because of the kind of relationship and the barrier that that brings. In addition to that, most of the informal setting interaction, you do not have the luxury, or you don't have the opportunity to see the history of this patient, to know their drug allergies or any other histories, that surgical history or whatever it is that you would need in order to make a diagnosis and properly manage the patient. Very importantly, most of these interactions are not documented. So they are done off the books, just a casual conversation, a prescription here and there, a test here and there. And in terms of continuity of care for this patient, this might be very detrimental in the long run. In addition to that, even though each physician or healthcare professional has certain implicit biases that may come to play in caring for any patient in general, when one is dealing with their family or their friends, that becomes even more heightened, and objectivity becomes a problem. Being able to properly request the right tests or information that you would need to be able to help in the management of a patient. And so we find that, like I said, even though the thought is that relatives or parents will get more quality care, sometimes there can be underdiagnosis or even overdiagnosis of a problem, and this can really be problematic. Lastly, and definitely not the only point, sometimes a physician may be forced to give healthcare advice which is beyond their expertise. And so, for example, you may have an ophthalmologist being asked by a family member about an obstetric or gynecological issue. And even though we have the basic medical knowledge, we all know that as we go on in our training, we become much better at the field that we are in. And so it becomes very difficult for one to give the most recent evidence-based knowledge on a particular issue. And this can be very detrimental to a patient's management. All in all, it's important that when you are faced with the challenge or the option of caring for your family member or friend, you take into consideration the foundational pieces of ethics, which is the autonomy, non-maleficence, beneficence, and justice, and make sure that in the setting that you find yourself and in the management dilemma that you are in, all these pieces are able to come to play without any problems in the management of that person. Okay, so the practicality of avoidance. As I said, almost all jurisdictions agree that it's best to avoid caring for close relatives and friends. However, I must admit that it can be sometimes challenging in various settings and for a variety of reasons. But it's very important to always communicate openly, politely, and honestly with your friends, with your family. Let them understand the limitations that you have and the reasons. Like I said, most of them do not understand that there are some disadvantages to that relationship. And it's important that we let them know, we communicate very clearly and openly about it. Then it's also important to serve as an advocate, even though you may not be in a position to provide that care to them. It's important that you let them know that you still care and you are able to serve as an advocate for them in terms of their healthcare needs, and be able to refer them to somebody who may be in a better position to help them. Okay. It's also important that we build capacity in this area in terms of training medical students and young doctors to understand what it means and the ethical implications of caring for your family and friends. It's important that we have open discussions on this subject with staff, both physician and non-physician, because as I indicated in the beginning, the physician-colleague relationship is also something that has to be explored and has to be understood, well understood in our different facilities, in our practices. So it's important that we have open discussions and get the viewpoints of all the stakeholders and come to an effective compromise. It's also important to have written guidelines and principles. That being said, the different scenarios that can come to play in terms of situations where you need to provide care for family and friends, and it will fall under an emergency, or it will fall under not convenience necessarily, but be in the best interest of the patient, vary. And so it's very difficult to put down clear rules that say yes or no, this is right or this is wrong. But with the written guidelines and the principles and the discussions on this area, we are able to get different points, and we are able to get different viewpoints, and it will help to be able to make decisions that will benefit the patient and also the physician in the long run. So in summary, when dealing with friends and family and their management, it's important to know that it is not a straitjacket. It's not a right or wrong, one size fits all. It's a balancing act, and it's important to put all the facts together, weigh the pros and the cons, and to also know the context in which you are operating, know the rules, the guidelines that govern the practice of medicine in that particular area. It's also important to offer help to the person, regardless of your decision to be the primary caregiver or the primary provider of the service or not. And it's also important that as part of our medical education and our ongoing medical training, we have these conversations and build capacity to allow physicians be comfortable and know what it entails caring for family members and friends as well. Okay, so these are the references, and I don't know if there's any questions, reflections. Thank you.
Well, thank you very much for reviewing an important and I would say challenging subject, because in healthcare, particularly as physicians and other healthcare providers, we want to be helpers. I think that's a major reason why many of us went into this, and we feel like this is a form of helping, but you've clearly outlined some of the downsides and some of the challenges. And I also want to say that Dr. Salia is kind of coming full circle. She was a participant in one of our Young Doctors and Nurses conferences, and she helped present this last March as an alumni, and now is part of the virtual training. So thank you for all your contributions. We do have a few minutes if there's any questions or comments from anyone that's on still with us. With seeing or hearing no questions at this time, we do encourage anyone to feel free to reach out to any of our presenters from today. If you don't know how to get in contact with them, you can always get in touch with me. You should have my emails from the notifications about these continuing education conferences. We'll be posting the recording on our YouTube Africa Partners Medical Training channel, and we're going to try and populate that YouTube channel with more and more useful information for anyone who's wanting to advance in their medical knowledge. And I'll just put a plug in for those that are in Ghana that are hearing this or seeing this real time, that Africa Partners Medical Ghana group has a lot of continuing education conferences on a monthly basis, both in person and some virtual. So don't hesitate to look at their website, africapartnersmedicalghana.com. And also be sure to check out the Africa Partners Medical website for ongoing educational opportunities and ways to become involved. And the last plug that I'll put in is for our next Young Doctors and Nurses Conference in person will be in Elmina, Ghana in October of 2023. And the dates of the conference are October 16th through the 18th, with people arriving on the 15th and departing on the 19th. And we look forward to communicating additional information about that in-person conference and the faculty that'll be participating and providing you with valuable ongoing information and opportunities to interact. So thanks everyone for participating with us today, or for those watching this online at a later time.